Great, well thank you so much. I'm delighted to be here. It's great to see people getting together for lung cancer, which of course is such a huge problem around the world in Asia and in India. These are my disclosures, and in particular I want to thank the AstraZeneca team for bringing me to meet with you today. So I'm going to talk a bit about frontline combinations for EGFR-mutant lung cancer. I'm going to focus on FLAURA2, but talk about some other data as well. To talk a bit more about patient populations that might benefit from intensified treatment, and talk a little bit about plasma testing and some follow-up testing as well. And so we know that EGFR-mutant lung cancer is common, much more so in Asia than in other parts of the world, like in Europe. And in India, it's estimated that it's anywhere from 25 to 30% of cases of lung cancer published by Dr. Singh, as well as colleagues in Mumbai. So clearly a very important disease, and very important in India, where we are seeing a growing number of women who are never smokers that are developing lung cancer, most likely in part due to air pollution, and a very high likelihood of EGFR mutations in this group. So it's been a few years now since we heard from the FLAURA study, and osimertinib has really emerged as the best first-line treatment for our patients with advanced EGFR-mutant lung cancer. And you can see that in addition to better progression-free survival compared to first-generation kinase inhibitors, we also saw better overall survival, although in fairness, not all patients crossed over to osimertinib, but many of them did cross over to other therapies. We also saw dramatic benefit in terms of intracranial progression-free survival, which I think is very, very important and speaks to some of the benefit of osimertinib in other settings, including early-stage disease. So the only problem is, when you start your patients on osimertinib, eventually that magic will run out, whether it's in 18 months, whether it's longer than that, or for some people, even earlier. And of course, the question is what to do next. And so there are different ways to think about intensifying therapy. Up front, when the patient is treatment naive, to have targeted therapy combinations to prevent resistance, or even adding chemotherapy. In the stage of minimal residual disease, where you've already shrunk the tumor down with osimertinib or another kinase inhibitor, and then you try and consolidate that response, for example, with radiotherapy. And finally, to wait until drug resistance, which is what we do now, and you can either then target something specifically, or I'll talk a bit about some of the less targeted therapies that we can use in the setting of osimertinib resistance. And so there are a couple of key questions. First of all, who needs combination therapy, as opposed to who are the patients that can live very, very well on osimertinib alone? And when should we combine? Should we do it initially, or should we wait for disease progression? And finally, with so many different options, who should get what? Or should everyone get the same thing? Can we personalize different combination therapies? And I've shown some of the examples of potential partners here, and I'm going to talk a bit more about adding chemotherapy. So the team here in India, of course, has really helped create history by demonstrating that adding chemotherapy to gefitinib improves survival. There's a similar study from Japan as well, which you know very well. But of course, the question was, when we saw these data, well, we also know that osimertinib improves survival, so is there a way to get that better outcome with less toxicity? So the question then became, well, we know chemotherapy helps in the setting of first-generation TKIs, but what about in the setting of third-generation TKIs? And we did see some interesting data at ASCO. This is a Japanese study where they initially gave induction TKI. First, they started using gefitinib, but as the FLAURA data emerged, they switched to osimertinib, and they presented these data at ASCO this past year. Patients got 3 months of osimertinib, and then they got 3 cycles of platinum doublet therapy as a kind of way to eradicate resistance that was remaining, and then patients went back on osimertinib as maintenance. And while you can see in the red line that patients had slightly better outcomes in terms of progression-free and overall survival, these were not dramatically different. So this concept that we had where you could just give a short burst of chemotherapy is probably not the way forward to improving outcomes. We heard about the FLAURA2 study at the World Conference on Lung Cancer, presented by Dr. Pasiana and colleagues, and this was a first-line study very much like FLAURA, but in addition to osimertinib, patients were randomized either to osimertinib alone or osimertinib plus pemetrexed and platinum-based therapy. They also then continued on that maintenance chemotherapy, so this concept of upfront chemotherapy to eradicate resistance early and continuing on rather than stopping treatment. Patients with exon 19 deletions and EGFR alterations were allowed, and patients with stable brain metastases were also allowed. They didn't necessarily have to be treated. Patients had initial MRIs of the brain done, but if they were negative at the time, they were not required to do them throughout the rest of the study. So these data, I think we expected. We expected that adding chemotherapy to osimertinib would improve progression-free survival. And the primary endpoint was PFS assessed by the investigator with a hazard of 0.62, which was clearly better with the addition of chemotherapy. And of course, we know that a more robust measure is to do this by independent radiology review, but the hazard was actually exactly the same. And I think for the first time in any study, the radiologists were even more generous than the oncologists with the results, and they found a median progression-free survival with osimertinib and chemotherapy of 29.4 months, and a very respectable PFS with osimertinib monotherapy of 19.9 months, even a little better than we saw in the FLAURA2 study. And when we looked at the different subgroups, all of the patients benefited across different subgroups, including those with different EGFR mutations, whether they were exon 19 deletions or L858R. I know that's often a question with first-line TKIs. And also patients with brain metastases at baseline had a hazard of 0.47 with progression-free survival, and patients without brain metastases also benefited. So the team presented a little bit more data looking at this in patients with brain metastases and without brain metastases, and you can see that even though chemotherapy is not supposed to work in the brain, that progression-free survival is significantly better in this high-risk group of patients with a hazard of 0.47 for progression, and also a very respectable 0.75 for patients without baseline brain metastases. We heard a little bit more at ESMO this year when they looked at intracranial PFS, and to my surprise, we saw that patients in red treated with osimertinib and chemotherapy had longer time to intracranial progression now. The previous slide I showed you overall progression, but this actually seemed to provide protection in brain, both in those with measurable and non-measurable disease on the left and measurable disease on the right. And the other thing they showed was intracranial response rates. And even though the response rates were dissimilar, 73% and 69%, or 88% and 87%, you can see in dark blue the very large number of complete responses that we saw with the addition of chemotherapy to osimertinib. And again, in theory, chemotherapy is not supposed to penetrate the blood-brain barrier, or not to a very great extent, but this really is extraordinary and suggests that there is something unexpected going on here in this very high-risk group of patients. Also, the median duration of CNS response, much longer, not yet reached, with the lowest number at 24 months, compared to 26.2 months median with osimertinib monotherapy. So again, an incredibly powerful agent in brain, or combination in brain. We also heard a bit about progression-free survival 2, or PFS 2. I've always thought of this as poor man's overall survival, but I think when you're thinking about giving something in combination up front versus in sequence, PFS 2 can be helpful. And what you can see here is that when patients start with osimertinib and chemotherapy, no matter what you give them subsequently, they continue to have a head start on our patients that start with OC and subsequently switch to chemo, and then other things. Overall survival to date, this is certainly early and not mature. These curves do overlap, and I think we'll have to see what happens over time, suggesting that there are some patients that benefit from intensified therapy and some patients that can still benefit from a sequential approach. Now, in terms of toxicity, I think we're very familiar with the toxicities of pemetrexed and platinum, as well as osimertinib, and there were no unexpected toxicities seen. As you would expect, more patients did continue treatment, but I don't know if you can see it, but the real thing that patients discontinued on the chemotherapy arm, let's see if I can get this to work here, actually was maintenance pemetrexed, and that's actually something that we see in real life. 3/4 of patients actually got the full dose of planned platinum for the 4 cycles, and it was really that sort of maintenance phase where I think we all know, due to renal toxicity and other issues, our patients often stop, even without the addition of osimertinib. So is that the only way with chemotherapy? And I think, there's been a lot of excitement. I think a lot of us came home from the World Lung Cancer Conference and thought, maybe we'll intensify in certain groups of patients. But we've also seen other data. I'm not going to torture you with this, but basically when we add VEGF inhibitors to EGFR inhibitors, we've seen fairly consistently in green improved progression-free survival, but in red I've highlighted that we consistently miss improving overall survival. We did see some new data looking at adding ramucirumab to osimertinib, again with a very nice progression-free survival improvement, a hazard of 0.55, very manageable toxicity, but I think we'll have to see in terms of overall survival how helpful this is long term. Again, another busy slide, but I'm just going to summarize them. When it comes to checkpoint inhibitors, I think as you've heard over the last couple of years, this is really a challenge for our EGFR-mutant lung cancer patients. When we have 3 drug regimens with bevacizumab and we add or don't add a checkpoint inhibitor, largely these trials are negative. When we just have chemotherapy and we add a checkpoint inhibitor plus a VEGF inhibitor, these tend to lead to better progression-free survival, but again, not yet overall survival, and we've seen some data over the last few congresses. And of course, immunotherapy by itself added to chemotherapy is not yet the answer, so I think we certainly need new and better drugs in this space for our patients with EGFR mutations. And what about targeting MET? We know that MET is the earliest and most common driver of resistance, not just to osimertinib, but first and second generation EGFR kinase inhibitors. And in truth, if we look more broadly, it is an important mediator of resistance across all targeted oncogenic subtypes, ROS1, HER2, and beyond. And what we've seen is that if we combine MET inhibitors with osimertinib, we do see improved outcomes. A number of studies now showing that if we select by MET gene copy number, we can really increase response rates and duration of response. We've seen that with tepotinib and osimertinib, and also savolitinib and osimertinib in the Savannah studies, where when we select by a copy number of 10 or more, we really do see dramatic benefit. Also, when we select by MET expression for antibodies, either the bispecific antibody amivantamab that targets MET and EGFR, or even atezolizumab, which is an ADC, you can see that consistently when we have that MET selection, we're able to get response rates in the 50 to 60% range and median durations of response out to about 9 months, as I've shown here. I think the other interesting lesson from the MET plus EGFR inhibitor data is that if we drop the osimertinib, if we don't continue the EGFR inhibition, patients don't do well. And we've actually seen this in the INSIGHT-2 study, where if you just use tepotinib, patients actually have a very low response rate and they're only on drug for a couple of months. So very important to remember to continue the TKI. We also heard some other data about other potential combinations. This is from the ESMO meeting where we heard about Mariposa with amivantamab and lazertinib. Again, very similar design to FLAURA2, the same patients, except in this study, serial brain MRIs were done in all patients on a regular basis. So this is quite a large study. Patients were randomized to amivantamab and lazertinib or osimertinib, and then for the FDA to evaluate the contribution of lazertinib, they also had a small number of patients allocated to that. You can see also a nice improvement in progression-free survival with a hazard of 0.70 and very similar numbers, just under 30 months median PFS, and also the osimertinib group did very well. You can also see in yellow that patients on lazertinib did very well, and similarly, but we don't yet know about the toxicity of lazertinib. And certainly using it in combination, I don't think we can say that it's as well tolerated as osimertinib. They also showed some nice PFS2 data, again showing that if you started with combination, that it was certainly difficult for patients on osimertinib to later to catch up. But again, not all of these patients were able to access amivantamab and lazertinib in the second-line setting. And in terms of overall survival, some crossing of the curves initially, the toxicity of this agent, potentially being a concern early on of this combination, but then perhaps an early separation. And there's a lot of censoring here, but I think it'll be very interesting to see what happens to these curves with more time. In terms of toxicity, well, this is a challenging regimen. I don't know if some of you have started, I know amivantamab has recently been approved in India, so I hope many of you are starting to use it. But in particular, when you double down on the EGF receptor, looking at the antibody and the kinase inhibition, you get more EGFR-based toxicity. I think the only difference was that there was more diarrhea with osimertinib and Mariposa. You also get some MET-mediated toxicity, such as edema, and of course, you're adding an IV drug that's once a week for the first month, then every 2 weeks. there's an initial risk of infusion reactions, and then the ongoing burden of IV treatment. The other interesting thing that we saw was thrombosis. So we actually saw thrombotic events in 37% of patients in the first 4 months with the combination. And so that's really led to now routine anticoagulation. So this really is a three-drug regimen, and I think there are a lot of open questions. How long do we anticoagulate for? What is it about these drugs? We don't see it with amivantamab alone. It's really this combination with lazertinib, and what is the underlying biology? So there are a number of other approaches of interest. I'm sorry, I'm just about to sail over my time. I think we've seen a lot with fourth generation kinase inhibitors. Those seem to be moving up to the first line setting. A study ongoing with Blue 945 that targets C797S. So can that with osimertinib delay the emergence of resistance? And then of course these targeted and yet untargeted drugs, the ADCs, patritumab deruxtecan, datopotamab deruxtecan, and these are also moving up to the first line setting in combination with osimertinib, trying to see again if we can overcome resistance with a less selective method up front. I think the other thing that's really important is radiotherapy. I think we often forget how important and how helpful radiotherapy is. We have a lot of data now suggesting that upfront radiotherapy with kinase inhibitors may improve survival, including from the CINDUS trial from a few years ago. And there are a number of trials that are ongoing looking at upfront osimertinib, consolidation radiotherapy versus upfront osimertinib alone, both in body, and we also did a study in brain, and we hope to present our results in the next year or so. So who needs intensified therapy? Who is high risk? Who needs a combination up front versus who can just wait on osimertinib and enjoy the benefits of a single agent monotherapy? And so I think, things that we think about in clinic, whether it's exon 19 deletion or L858R, who's willing to have IV infusions, patients with brain metastases, as we saw in the FLORA-2 study, and then perhaps younger patients with greater disease burden. I think there's also a lot of interest in different biomarkers, which we'll talk about, and of course the big question, how much is improved PFS worth versus overall survival? And we know that there are patients in clinic that we already identified, for example with TP53 mutations in the top left, where these patients have a worse prognosis than our other patients on kinase inhibitors. We also know that our patients with TP53 mutations and RB1 loss at baseline are much more likely to develop small cell transformation, and is that a group where we should perhaps intensify with a FLORA-2 approach? Finally, we know that in patients with ctDNA at baseline, these patients do have a higher risk, but if they clear their ctDNA with osimertinib, they do much better. However, if they don't, as you can see here in yellow, these patients do have a risk if they don't clear their ctDNA. So could we do an adaptive approach where patients get some osimertinib? If the ctDNA is negative, they continue on single agent monotherapy, and if it's not, we randomize them to add chemotherapy or not. And that's a trial that's ongoing, led by Dr. Helena Yu. We're hoping to bring that study to Canada in the next few months. So just to sum up, I think for many of our patients, osimertinib remains the standard of care in the first line, but it's clear that combinations can improve progression-free survival. Who needs which, I think, remains to be fully defined, but we're starting to get some hints from the data. Patients with higher risk disease, patients with more concerning co-mutations, patients with brain metastases, these might be groups in which we intensify. And I also think that the long-term treatment with osimertinib, the challenge, of course, is how do we attack resistance? And there are many new approaches that are being developed, and we need better approaches still. And so with that, I want to thank you. Thank you for letting me go over time. I've had a great time these past 3 days in India. 3 days, 3 cities. I started in Delhi, then I went to beautiful Hyderabad, and of course I'm here in beautiful Mumbai with you, and I want to thank you so much. I also want to invite you sometime to come and join me in Toronto. You can see that it's very sunny in Toronto as well, but do note the difference in temperature and bring your warm clothes. Thank you so much.